Thank you very much, first of all. Very overwhelmed but honoured and proud to receive this award this year. I was asked to just give a short talk on my work, which is actually quite challenging because, as Brendan alluded to, I've been here for over 10 years now. And during that time I've worked in a number of different laboratories listed here. And whilst I've always worked in the area of HIV research primarily, I have worked on a range of different projects. So instead of just speaking about one story today, I thought I might just give a snapshot of 3 little projects that I either currently do or have worked on in the past, which I think they're quite diverse projects, but I think that reflects the diversity of Burnet, I think, which is one of our strengths, and it's certainly one thing about Burnet which I love. So I'm just going to speak briefly today on my HIV research at Burnet, from antiretroviral therapy to the heart via the female genital tract. Which is a little bit of a journey, so strap yourself in. So we begin in the Papua New Guinean Highlands, which is a good place to start, monitoring antiretroviral therapy. So as we all know, poor adherence to treatment and drug resistance both threaten the efficacy of antiretroviral therapy. This is particularly important in countries that use standardised ART regimens, i.e. everybody gets the same set of drugs. Particularly in these settings, often access to clinical monitoring assays like viral load testing is limited or non-existent. So it's important to ensure that these drugs remain effective for the population they're applied in. So together with Suzanne Crowe, we supervised a PhD student, Janet Gare, who looked at ART adherence in PNG and looked at some of the factors affecting this. She made a number of findings, but looking at adherence, she found that probably only 40% of people on therapy actually had what we'd call excellent adherence, which is relatively low. And probably more concerningly was that almost 14% of them were failing therapy, so on therapy but had detectable virus. And these people wouldn't have been aware that they were failing therapy because at that time, and still to this day, viral load testing is not widely available in PNG, if at all, in many places. So whilst working in this lab, I developed assays to measure HIV drug resistance and optimise these for use with dried blood spots, which is really an ideal sample collection tool for use in resource-limited settings where access to things like fresh and frozen plasma is difficult, if not impossible. So we use this technology to conduct the first surveillance of transmitted drug resistance amongst people recently infected with HIV who are yet to start therapy in Papua New Guinea. This was a study done in conjunction with the WHO, and was done at 2 sites, in Port Moresby and also in Mount Hagen in the Highlands. And whilst we found that resistance to the NRTI class of drugs, which is a part of the backbone of antiretroviral therapy, was relatively low in both areas, resistance to NNRTIs was significantly higher, 8.2% in Mount Hagen and 16% in Port Moresby, which is classified as significant resistance. These levels were actually some of the highest levels of transmitted drug resistance that had been reported globally at this stage, particularly in a country where therapy hadn't been available for that long, and were quite concerning, and important implications for the efficacy of standardised ART regimen in this country. So these findings really prompted WHO to initiate a nationwide multi-site HIV drug resistance study, which is currently being initiated. And as I mentioned before, Dr. Janet Gare completed her PhD here at the Burnet. We're very proud of her achievements both here and what she's taken back to PNG. She's now heading this multi-site, quite large WHO study. So very proud of her and happy to know that this work is continuing on in country in safe hands. So moving from the ambient environment of the Papua New Guinean Highlands to arguably a less ambient environment of the female genital tract, we've been looking at the role that the microbiota in the female genital tract might play on risk of acquiring HIV infection. So within the genital tract, of course, the female genital tract, we have layers of epithelial cells which separate the vaginal lumen, where pathogens like HIV would usually enter, from the blood and HIV target cells that are in the sub-epithelial space. And just like in the gut, where we know that there's good and bad bacteria, in the genital tract this seems to be the case as well. And the good guys seem to be the lactobacilli. So women with lactobacilli-dominated microbiota, they have high concentrations of lactic acid, which is a metabolic byproduct of these bacteria. These women typically have a low or a non-inflammatory environment, and having this microbiota is associated with good sexual and reproductive health outcomes. The flip side is what we call vaginal dysbiosis. Not so much a bad guy, but a combination of diverse microbiota that lack this lactobacillus and therefore lack lactic acid. And this is typically associated with increased inflammation in the genital tract. And that's bad for a few reasons. One is it increases the activation and recruitment of target cells to the subendothelial epithelial space, particularly HIV target cells. And in some studies in young women in South Africa, it's been shown that this kind of microbiota is associated with a significantly increased risk of HIV acquisition. So this one study showed 4.4-fold increased risk of acquiring HIV if you had this sort of diverse microbiota as opposed to women who had a lactobacillus dominated microbiota, so quite a significant impact. So we undertook some work to look at the effect that lactic acid has on immune cells, so the immune response of cells that line the female genital tract. And just a quick summary, we found that lactic acid itself actually has quite potent anti-inflammatory effects on these cells, so it stimulates the response of anti-inflammatory cytokines. And more importantly, it actually prevents or protects against inflammation that's mediated by viral and bacterial pathogens that might enter and activate these cells. So it helps maintain this non-inflammatory or anti-inflammatory state. These findings suggested that lactic acid, that specific product of the bacteria, is a significant contributing factor to the protective effects that we see in women with a lactobacillus dominated microbiota. So this discovery was actually patented by Gilda Tashigen, who was kind enough to list myself as a co-investigator. And she's currently leading a project developing a lactic acid containing intravaginal gel, which is going to undergo pilot studies in conjunction with the Melbourne Sexual Health Clinic here to assess efficacy and tolerability. Well, the end goal really is to help develop female-initiated strategies to help maintain good vaginal health and to protect against infection not only with HIV but other STIs. These female-initiated strategies are particularly important in parts of the world where we work, where women often don't have the power to negotiate condom use or other preventative strategies. So the last topic I'll just touch on quickly is the heart, which is a nice place to end. So in countries like Australia, where we have excellent access to anti-HIV therapy, people are living a longer, almost near normal life expectancy now with HIV, which is fantastic. What we are noticing, however, is that these people have an increased risk of what we typically call age-related diseases. So frailty, neurocognitive decline, osteoporosis, significantly more common in people with HIV. And cardiovascular disease is one of the biggest ones, and it's actually the leading cause of mortality in people on with HIV who are on effective CART. So HIV positive people have about a 2-fold increased risk of CVD, which is similar to the risk that is associated with smoking cigarettes, which we all know is, it potentiates cardiovascular disease quite significantly. Importantly, this risk does persist when you adjust for all those other traditional risk factors such as smoking and family history, male sex, etc. And also after you adjust for the effects of therapy. So there's something specific about HIV that's driving this disease. So most cardiovascular disease is underlined by the development of atherosclerosis, which is the thickening of the artery wall due to the deposition of lipids and cells within this subendothelial space. Causes a narrowing of the artery. This can then rupture. You have a plaque rupture, blood clots, etc., and then that can lead to your cardiovascular events. So there's a type of white blood cell called monocytes that play a really important role in these early stages of atherosclerosis. They migrate from the blood through the endothelial layer into this subendothelial space within the artery wall. And in here they take up lipids. They turn into macrophage and they take up lipids. At this point they can either move out of this space, taking the lipid with them, which is a good thing, that's associated with regression of that plaque. Alternatively, they can remain in that space, take up lots more lipid and become big fat foam cells, which then undergo necrosis and release lipids, inflammation, etc. And that's associated with plaque progression and rupture. So previous postdocs within the lab set up an in vitro model of early atherosclerosis, where we basically try and model this step. So we stimulate this blood vessel wall. We have a matrix at the bottom. We layer this with activated endothelial cells. These actually come from the veins of umbilical cords from babies, once they're finished with them, obviously. It's a very messy procedure, trust me. We then take blood from individuals, and this can be healthy controls or this can be HIV positive individuals. We isolate their monocytes and then we add them into the assay. leave it for a couple of days, and then we can analyse what these monocytes do, whether they just turn into macrophage or whether they turn into these big fat-filled foam cells. And we can count these by microscopy, and we also have some other fancy ways to look at these cells as well, which I won't go into today. So using this model, we've shown that monocytes from people with HIV are more pro-atherogenic. And I'll just touch on 3 or 4 points where we've showed this. First, we looked at the monocytes and we found that their ability to efflux or get rid of cholesterol is impaired. So they can take it up, but they can't get rid of it. So they have this propensity to accumulate cholesterol and lipid. Secondly, we've showed that their ability to get out of this subendothelial space is impaired. So they are more likely to be retained within this space, within the plaque, if this was within the body. And also that they have an increased propensity to form foam cells. So they're more likely to take up lipids and become these foam cells, which we know is bad for plaque progression, is associated with plaque progression and cardiovascular disease. We've also looked at the serum factors, so in the serum of individuals, and we've looked at what's traditionally called good cholesterol, or HDL, and this is a little bit of a case of good cholesterol gone bad. So whilst the levels may not be different from one individual to another, we've found that in HIV individuals, their good cholesterol doesn't work the way it should. It's actually dysfunctional, and it promotes this formation of foam cells. So this is potentially a novel mechanism that might be driving atherosclerosis in HIV, and is quite exciting to follow up at the moment. So this was some of the first mechanistic data really explaining the increased cardiovascular risk, and in particular the association that we see between monocyte activation and increased cardiovascular risk in HIV, and might help inform us about how this process is happening and therefore how we might be able to prevent it in people who are living longer with HIV infection. So thank you for your patience with my journey. Thank you once again for this very amazing award. I'm very flattered. Some of the wonderful people I've worked with over the years are listed here, are sort of pictured here, not all of them, but I've been very privileged to work with very inspiring and wonderful colleagues and mentors here at the Burnet. So thank you very much.